We ready, Sandy? Sandy, you need to unmute. We can't hear you.
Hello, can you hear me now?
Now we can hear you.
Welcome, everyone. This is the ongoing series, and this time it's an endoscopy gecko. And I'd just like to welcome everyone. Gecko obviously is the University of Mexico initiative, and we are sort of part of it through the Gastro Foundation. And this is our regular weekly slot on a Wednesday. Again, we've got approximately 60 registered, and I think currently we've got about 30 who are logged in. And welcome to those from a variety of different countries, from Cameroon, Ghana, Kenya, Maldives, Mozambique, South Africa, Zimbabwe, Tanzania, Saudi Arabia, and we've got someone from Brown University, not sure exactly who that is. So it's, as usual, a mixed audience, and we hope you enjoy what we've got on offer. First up, we're going to talk, this session is about training and possible initiatives that we can use and some principles of training. And Chris Ziady, who's now in his semi-retirement from his private practice, has moved into Sefako Makato University, and he's going to be developing their teaching modules for endoscopy training in a variety of procedures. And so he and I have had discussions about how we might help each other with those initiatives. And he's kindly agreed to talk on the principles of teaching endoscopy. And really, I can say no more than that. He is a very accomplished endoscopist. I don't know what his special interests are, but probably ERCP and EUS, but I think he's pretty master at most of the procedures, and has been involved in workshops in a variety of different settings. So if I can ask you, Chris, just to share your screen with us and give us your talk. Please remember that we would like questions. Again, this is meant to be interactive. So please post them in the chat, and we will get to them as at the end of the procedure. I think we'll take questions after the end of his talk, just to see where we are. And then we can move on to my talk, which is on a slightly different theme. So over to you, Chris.
Chris, please unmute yourself.
Says to me,
We can hear you.
Now? Great, okay. Thank you, Sandy, for that kind introduction. Some people have said to me, it's not a partial retirement, it's an unsuccessful retirement. But let's get on to the topic we've got to discuss. And this is about endoscopic training. And this is an issue that I've approached from a management by objective method. Why I've used this, and this is not a new system, this is something that's existed in the business world for a long time. I was first introduced to this system in the 90s. But it's all about setting up objectives and then planning how you get there. Why I'm going to do this, I'm giving you this as a background first, and I'm going to give you the basic structure, is because when you read articles on endoscopic training, you will immediately recognize the language they're using coming out of MBO methodology. So let's quickly, now for some reason, I am not making progress. I'm going to stop sharing and start again.
Okay.
Okay, let's see. Also not working. Why is that? Oh no. Let me do it again. Okay.
Yeah.
There's 3 slides here to just describe briefly what this management by objective is about. It consists of 4 steps, and it's literally the what, how, where, and when of reaching an objective. The first obvious statement is you need to decide what the desired outcome should be. You plan how each of the intermediary objectives will be met. And when applicable, you determine where each objective will be accomplished, and that has got application here in endoscopic world as well. And then you need to have a time frame. The when is important because you must have an endpoint in view. When you're setting up this equation or this determination of the objectives, you need to answer some questions. Firstly, is the objective worth setting? And let's bring endoscopy into picture. Is a local, national, or any other form of endoscopic training standard, is it worth setting? You can make up your own mind about that. Is the objective practical? In other words, can it be attained? Question 3. And then is the objective clearly stated in terms of the task you're applying it to, the methods of measurement, the time frame required. Now, what's important is that all the answers to these, and there's a 5th one that I didn't include here, because it's not applicable to our topic. All the answers must be yes. If you have a query or a no, a definite no, you've got to go back to the drawing board. The second step after that is you have to have detailed operational plans, and that's the how. You have to have measurement methods. In our language called competency appraisal. And then the time frame is usually determined by other factors, people rotating through the unit or whatever. So that's not usually a limitation, but it might be for the stragglers that are not reaching competency. Okay, so we're going to talk about the how. And one has to remember to participate, to fully participate in this system for training, endoscopic training, you've got two components to think of. One is the trainer, and I'll address the trainer's needs first, because without the trainers being first aligned to the task, the rest can't happen. So the trainers actually have to get the first training of the system. The trainees are the obvious targets of the training. And I'd just like to mention here that worldwide, the last decade has seen a change in emphasis of training. And no longer should we be seeing logbooks and numbers. Those don't guarantee competency at all. They may guarantee attendance, but that has very little relationship to endoscopic competency or skill. Much like trying to drive a car, learning out of a book and not doing it behind the wheel. Now to address the trainer's requirements, the training skills are very specific, and are not automatically acquired. A person who is a very competent endoscopist might be a very poor trainer, and actually the good teachers have to be separated out, and they might not necessarily be the best endoscopists. Sounds a bit strange, but that's actually what you have to realize in this. So this is the first step, to train the trainers. It's not a once-off, it's an ongoing process. And between the trainers, if you have multiple trainers, peer feedback is very helpful. In other words, cross-questioning one another, listening to one another's instruction through a procedure, that all helps to build up an effective trainer. Also in one unit especially, the trainers should develop consensus on what and how skills are to be taught. There must be consistent message throughout the training center. You can think how confusing it will be if one person says this and another trainer says something else. That's not conducive to good learning. Some of the components during colonoscopy, for example, you need to have tactile feedback, which as an onlooker, you don't immediately appreciate. You can't see when there's resistance to torque or in undoing loops. You need to explain that to the trainee to know what to expect and then watch them while they're doing it. It is again something, it's got to do with communication. And there are systems in place how this is done. But it takes careful observation of the trainee during his procedure. And it takes clear verbalization of the sequential steps by the trainer. So when a trainer is unconsciously competent, they need to actually step up and become consciously competent. In other words, deconstruct how they did and got to where they got before they can actually teach that. And that's the difference between a good endoscopist and a trainer. Okay, let's look at the needs of the trainees. It obviously has to be adapted to the trainee's needs. If you are training somebody in colonoscopy, for instance, your first question is, how far have you got to? What are your challenges still? And if the candidate says, well, he struggles to get through the sigmoid, then you know where to apply your attention and give him his best part of the training. So there's got to be this constant communication. Now, it helps during the training sessions that goals should be agreed on by both the trainer and the trainee, so that it's clear where you're going. You do that before you start. You set your goals. And then feedback for the trainee from the trainer is absolutely vital, and that's how they will progress. Feedback, by feedback, I mean they need to know that they're either listening to you carefully or not listening to you, or not doing what you're saying, or there's another way to do it. But they need this constant checking of whether they are on the right road or not. Now, in the background, at all times, the patient's safety is paramount, and that might determine when the trainer needs to take over. Factored into this whole equation is the role of assessment of the trainee. And the trainee must have full insight into this assessment as well, because that is part of the feedback which assists him to make progress. Okay, I just to see in the audience who's been exposed to this kind of these training methods and assessment. We'd like to have a quick poll and just a yes or a no. Have you been involved with training competency assessment before, either as a trainer or trainee? You can vote and then submit your votes. I'm not sure if we're going to all see the result.
It's coming
Is it,
in.
Cheryl? Okay.
It's coming in. We've got 24 of the 33 that voted so far.
Okay.
So we'll give it, okay, I will end the poll.
We just like to see how much experience. Oh, it's 50-50. My goodness. Okay. Right. So we're talking to an educated audience by and large, 50% at least. Great. So this is Cheryl. I've stopped progress. I'm not sure why. I can't move my slides on. I'm going to stop sharing and start again at the next slide.
Are you okay there? Okay.
It's not moving. That poll did something to my, oh dear me. Okay, what I will have to do now is.
Chris, you must close the PowerPoint and then reopen it and then
Yeah.
share the screen again.
I've done that, Sandy.
Yeah.
Let's just. Oh no. There we go. Right. I hope that's visible on your side.
Yes, we're good.
Please.
Okay. The first signs that a really well-structured training program was evolving for colonoscopy specifically occurred in the UK about 2012 already, almost 10 years ago. And the system was called Direct Observer Procedural Skills. I'm sure that's being updated as time has gone on, but the failings there is that it was primarily an observation of procedural skill, but not cognitive skill combined with the procedural skill. It was an assessment only of technical aspects of the examinations. US tried to improve that. A few years later, they came out with a next NAS system, further refined by Mayo. The Mayo tool was a very accurate tool, reproducible and very, and people can compare numerically, even in different universities. So that was real progress. The only problem there was they did not include measures of competency of the endoscopy in terms of adenoma or polyp detection rates. So that was a failing. That was addressed in the next assessment of competency in endoscopy developed by ASGE, shortened down to ACE. Now, I'm going to give you an example of that, and you'll see it's extremely thorough. It's extreme. It assesses all types of the candidate's competency. Then one of the questions which has arisen: how often do you assess the candidates? You're training them obviously all the time, but how often do you actually do a competency assessment? And it looks like 10% of the procedures that they're doing. In other words, every 50 colonoscopies that they have done, you would select out the next 5 sequential colonoscopies to assess them. And then bear in mind, there are going to be those who struggle. You have to define in advance what the minimal competency threshold is. For example, you have to set the standard of minimum cecal intubation rate of more than 85%. And time to cecum, 16 minutes. That might surprise you, but that's achievable by a person who's at the end of his training deemed competent. Now, this is the Asg Assessment Tool, and we're not going to go through this. I'm just giving you this as an example of how detailed the assessment is. And as I said, not only is this for the trainer's benefit, but for the trainee as well. They must see where they're failing or where they're not achieving competency. And if you look at the breadth of the assessment, it starts off with the indications, underlying medical issues, vitals, allergies, etc. Included in the training has to be sedation principles and what to do when a patient is feeling discomfort during the procedure despite what the sedation you've given. The whole point is that sedation alone requires training. I'm not going to go through all of these. As I said, there's coming up about 14 or 15 of these observation points. And it ends down here, overall assessment. So then the person is basically classified as novice, intermediate, advanced, and superior. Those are the hands-on skills, and his cognitive skills, that's in short, situational awareness, anomality interpretation, decision-making skills, those also evaluated, and again, classified. So the candidate then can see where he is on an objective scale. You take out all subjective bias, hopefully with this system. Now this exists for all the other endoscopic procedures, for upper GI endoscopy, and also similar tools exist for endoscopic ultrasound and ERCP, shortened to TSAT. That's tools for endoscopic ultrasound and ERCP assessment tools. So I have not listed them here, but the literature is available if required. Other forms of training. That, in other words, how else can patients be trained? Simulators are playing a bigger role. It has been shown, and there have been at least 21 randomized controlled trials done to see if simulators aid training. They've definitely been shown to reduce the time taken to competency. And it allows teaching of rarer procedures which are seldom encountered in the patient and which the candidate might not encounter, but he needs nevertheless to know the principles of management. Also important is you can now teach the candidate how not to do something. In other words, if you're going to go through a sigmoid, you can show them what happens when you just push, push, push and not straightening the scope out. That you cannot do live. Personally, I found EUS simulator training extremely useful. And Well, for example, I'll just give you my own personal experience there. I was introduced to EUS in about 2006. I only started doing EUS because the hospital that I worked in purchased a unit in 2010. And up to that point, before we had an EUS apparatus in the hospital, the most effective training that I'd done up to that point was on simulators. Now I'm talking about, let's just divert to EUS training in general, because it depends. If you take an endoscopic novice and try and train them EUS training, that's going to be a huge long curve. If you take a person who's experienced in ERCP as well as ultrasound, your curve gets proportionately shorter. So when I said to you, I was introduced to EUS at a specific time, I was talking on the back of at least 5,000 ERCPs, if not more, and doing abdominal ultrasound in my consulting rooms for, again, 10 years maybe. In other words, the basic principles of the scope management and the ultrasound pictures were already familiar. Despite that, it took me several years, probably 2 to 3 years, before I could say I reached any form of competency and confidence doing EUS. Bearing in mind, we had no trainers locally, but I won't go into that part. All right, so the next thing about simulators, the trainers can use the simulators as well to hone their communication skills. And what's been improving over the years are the virtual reality pictures that you're seeing from simulators, and they're getting really, really accurate now. The downside is the cost. Unfortunately, they have limited applications. They do not do, you cannot do all the things that you do live in as you'd like. So they're really for basic learning, and they're not available everywhere because of their cost. Now my screen has frozen again. I think I only have one more slide, and I'll just talk you through it, and that is animal models. We've had several endoscopic workshops done using animal models, and these have been very, very useful for specific tools that industry has brought and has trained individuals in the country. For example, submucosal dissection principles, hot axis use, POEM procedures. Now, those animal models are really exceptionally useful for training a specific procedure. And the unit that you'd need to set up needs to be accredited for that. There are certain limitations in using animal products, but if that can be integrated into the training center, it's a very valuable inclusion. I think that's the rest of my talk. I'd welcome any questions, because this is a huge subject, as you're aware of.
Yeah. Thanks very much, Chris. It's such a difficult job to sort of encapsulate all the sort of training principles, but I think you've done a very good job of that. You touched on the fact that you sort of moving away from logbooks into competency assessment. So could you sort of enlighten some of us about how many colonoscopies it takes to achieve on average, for an average trainee to achieve competency? That's however you want to define it, but say a 90% or 85% fecal intubation rate.
Okay, different countries have different specifications, or used to have, in terms of numbers, when they were still using numbers games. And in ASG had a number of 140 colonoscopies. And what they were finding with this method of training is that they underestimated the amount of examinations required before competency. So in general, it seems like our numbers in any case were too low in the past.
Yeah.
That, unfortunately, will vary from country to country. Lower resource countries, lower countries with resources, I'm talking about physical resources, trainers, lack of trainers in many countries. And I think we have to include our own country as one. We can't afford to go beyond a certain limit of say, colonoscopies, for example. There's pressure on the trainers and the trainees to get to achieve competency. But in general, I would say for colonoscopy, it's at least 150 colonoscopies before competency.
Obviously,
others vary too much.
Yeah.
For example, EUS, the figures in the States, using competency as a guide, using competency as a guide, it was thought beforehand that about 200 EUSs were sufficient to arrive at that point. But now it's found that some candidates will arrive there in 250, others will take 350 to arrive there. So there's a huge difference in the skill learning ability of the candidates. And this system takes that into account.
Okay, yeah. We did some work on that. Dr. Chinnery did some work on that. And there's no doubt that the trainees vary in their ability to reach these. But I think in UK, the training system in the UK, you won't be signed off for colonoscopy with under 200. And the average number to competency is 256. So these numbers are quite large. And again, I think they have implications as to how you might want to structure your competency assessments, whether you need to lower them down if your volumes are smaller as to what you want to achieve.
There's another physical limitation on that, and that is the trainees will really suffer from an overload of or download failure from too much input. And there's a limit at which you can push this.
Yes. There's a hand from Eileen from Ghana. I wonder if you could unmute and even switch your video on and tell us what your question is. Eileen?
Sorry, accidental, so I've lowered it.
Sorry, can you repeat the question?
I said I accidentally raised my hand, so I lowered it.
Oh,
sorry.
That's good to hear the voice behind the name.
That's okay.
And
so,
if I could ask a question, Chris, thanks very much. What about maintaining competence amongst trained endoscopists?
Correct.
And often that's found to be more difficult because, you know, it's often viewed as an intrusion on your practice, and it's sometimes more difficult to kind of get people to accept that they need to be that their training needs to be readdressed and touched up, much like opera singers need to kind of be recoached and retrained at points in their career.
Chris, one can be a bit philosophical here. I think as doctors, we all appreciate in our business, you never stop learning. If I go to, well, I haven't been to overseas congresses for a while now with the COVID thing, etc., but if we were to go to congresses and I were to attend an educational center or learning center, which some of the companies run during the course of congresses, I go to the basic things. I go to the colonoscopy teaching tools and I look what's been happening. I want to know what the Douglas Rexes are doing. I want to know what the Matthew Burkes are doing in the world. Previously, it was the other big names, the Christopher Williams and Jeremy Ways, etc., etc. So all I can say is we must never stop learning. And if it needs encouragement by means of accreditation, so be it. We don't have an accreditation system in our country. I would say that's unfortunate, because then it would be built in, whether you wanted to be part or didn't want to be part, it would be forced on you. Yeah. But I think it's an attitude thing. One should be willing to learn again, and the basics, including the basics, because they do change. Scopes change. A lot of things change all the time.
In UK, they monitor all the consultant colonoscopies now through the JAG system, and so ongoing training is monitored not by competency assessment but by key performance indicators. But if their key performance indicators, such as cecal intubation and adenoma detection rate, fall below a certain level, then they have to go to one of the training centers and retrain. It's mandatory. And I think it's the only system in the world where that occurs. And I think for colonoscopy, the training manuals are very much better written than for any other endoscopic procedure in terms of validation of outcomes. So I think it's round about 100, they would say, is the minimum. And for ERCPs, the figures that are quoted now from objective measurements are around about 60 a year for you to keep your hand in. So there is a minimum volume, which if you don't attain it, you're unlikely to maintain your skills.
Sandy, there's a comment from Julian Utley, audit. Perhaps, Julian, you could unmute and elaborate.
It's not particularly complicated. You just keep a record and someone monitors your performance. So when I was at the Donald Gordon, we all submitted all of our performances, and that could be reviewed on an annual basis.
I admire you for doing that. And we've also been assessing some of the key performance indicators, but not all of them in Cape Town. I think in the next endoscopy session, we will hear Kay Carlson speak to some of the results from your Donny Gordon Centre, and I think it's long overdue that we start to keep key performance indicators for all our endoscopic procedures. They're out there, and they're the only way that we can really assess ongoing competency.
Sandy, can I comment? Another comment there is you get the nurses to fill out the audit forms. So it's not the endoscopist, but the nurse has to agree that you actually got into the ileum, or that when you left the cecum, the time was 15:04, and when you got to the rectum, it was 15:06. So
yes, I think accurate timing is definitely necessary, but I think you should go for photo documentation as well as verification by the nurse, and we should all be doing that. That's really quite simple to do now. Even if you don't have a sophisticated endoscope, you can capture these images quite simply. So I think photo documentation is another part of your audit system. You should be taking pictures of key performance and key anatomical landmarks. Yeah. Shall I continue, Chris?
Yes, Sandy.
So I'm going to now move on to a slightly different aspect of training, and I will touch on some of the things that Chris has said, but there's really not much overlap here at all. I'm going to talk about telementoring, and hopefully you'll find it will be interesting to see your comments on this. Hopefully you can see that.
Yes, we can.
That's good. So I've entitled it Opportunities for Endoscopic Training Using Telementoring. And if you could shove up the first poll, I want you just to answer or consider what you think is the best definition of telementoring. And I will leave it up for a few minutes because you may need to have some thoughts on these aspects. How are we doing with the participation?
We've got to 25% so far.
Okay. 25 participants or 25%?
Percent of people that voted.
I see.
Standing at 34. Should we see? Okay.
Yeah, just give it another second or two. All those who are recalcitrant, it doesn't matter what you vote, and there's probably no right or wrong answer if that helps you to. You're not going to embarrass yourself in public here. So please keep voting so we can get a true reflection of what you think.
60% you voted.
Okay. Yeah, if you can close it now and just share it. Yeah, I think all these definitions are actually from the internet itself. But I do think that number two, B and C, B and E are the correct sort of definitions that I'm going to be talking about just now, because I'm going to talk about procedural telementoring. And that again illustrates some of is part and parcel of being a good trainer. So I'm just going to give you a little background about how I got into it. I've been with the WGO for a long time, and these are actually what are called training centers in Africa. And these are the other training centers around the world. Probably the one that is most similar to the training centers in Africa is the one in Swawa in Fiji, which is supported by the Australian Gastroenterology Society and the WGO. They are really very resource poor and essentially don't run a colonoscopy service, only an endoscopy service. But there is a whole degree of sophistication around these centers as to what they can and can't do. And some of them are participating in telementoring activities. I first got interested in it when I was in KwaZulu-Natal, and the gentleman on the left of your screen holding the one with the most beer out of it so far, that's Shimizu. And Shimizu is part of the Telemedicine Development Center in Asia. And I've linked with him over the years. And when I first came to Cape Town after 3 years, he came and visited, and we set up a live demonstration with Japan. We took live surgery via some special software that he had that we got that ran on a computer. And basically it was the poor man's way of taking live endoscopy. They took the trouble to come with a technician to see us and to vet Cape Town to see if we had the bandwidth to be able to do it. And fortunately we were. So I've been thinking around with telementoring, and in fact, telementoring's been around for a long time in surgery, much longer than it's been around in endoscopy. And the focus on it has only sort of come to gastroenterologists and endoscopists more recently. And this is the sort of first proof of concept. This is an island in the middle of the Baltic Sea. That's a gentleman on the left. He's well trained in ERCP, but only does about 20 a year. And the gentleman on the right is sitting in his office in the Karolinska Institute. And those 3 images that you see beside his hands. You can see that he's dying to take over the scope, but he's got all the images there, the fluoroscopy image, the endoscopic image, and the external camera. So they published this now I think 8 years ago. And this is actually the distance between the two. The place on Gotland is called Visby. And they showed that it worked and that it was very helpful for an individual who was not naive. So it just so happens that Ed Jonas, who's I don't think on the call today, goes there and does a locum every year when he was there. And he went back there about 3 years ago. So we decided that we would try and link up between my office in Cape Town and the ERCP room in Visby. And this is their system there. This system is a video conferencing unit, and most of us are familiar with that for business meetings, and when the university has equipped numerous venues for that so that they could conduct meetings. So it is indeed the same equipment that we've actually got, that I got in, managed to purloin at UCT. And so this is the image in my office in the same machine. And he was doing a difficult case with the recurrent stones. So I telementored Ed Jonas, who was perfectly capable of telementoring himself, as to how to get out these big stones. They were fortunately soft stones. And again, we could interact real time with the endoscopic image. You can see the stone here, and with the fluoroscopic image. And if we wanted to see the external view, we could switch between it. The other thing that in Africa that has happened now is that most of the countries now have what's called an academic network. That means if you're in a university system, that you really have free access to large bandwidth internet access. Again, one of the problems is that the network might be in your university, but is it in your hospital or your university hospital? And is it in your endoscopy area? And more, these things are starting to be built into endoscopy and theatre complexes when they're redesigned. And if you're redesigning an endoscopy area anywhere, you should try and get this built in to where you're coming. And the good thing is that it's cheaper to do this now, and you can do it simply with network cables that are relatively cheap. This was the first time that we actually used it. We used it when we brought the JAG system over here to run a train the trainers and training course. And we just used it from our endoscopy suite to our library. So that's about 50 meters away, so that we could have remote discussions about how the endoscopists and the trainers were performing. And I think that's one of the other aspects that Chris didn't fully touch on, and that is the fact that you need to run training of the trainers. Just because you're an expert endoscopist does not necessarily mean that you are a good trainer. If you've ever seen Chris in action, some people are natural at it, some people can work at it, and some people will never pick it up. And I can come to that in a little minute. And this is what I would like to sort of put forward. These are the sort of, if you see the graph, you can see that there's lots of skill sets. Some of them are cognitive, some of them are to do with decision making. You can make many more lines here. And again, you're trying to get up to this line here where you've got operational competence. And it does take time, and those times do vary. But hopefully, if you've got good teaching technique, you can move it towards the left. But I do think that telementoring is not really for the basics. The basics should be done in the simulators and in the lab, in the animal models that Chris has alluded to. But when you come to advanced therapeutics and even core therapeutics, you do need to be able to have continued exposure and continued supervision with these, partly because of the volume issues, that you need to see a certain number and encounter a certain number and do a certain number to achieve these levels. You can't get away from the fact that numbers aren't the beyond and end all, but if you don't have the minimum number, you will never get good at the procedure, even if you're good at other endoscopic procedures. So what's happened now is that in place of the teleconferencing unit, which again allows these inputs, you can now connect your endoscope, your fluoroscopy, your ultrasound, and an external camera to a capture device, a multi-port capture device. That may be in your computer or external to it. And obviously you've got the trainee who's wired up with a wireless headset. Wireless headsets are really quite cheap now, and they're of high quality, or you can use a Bluetooth one. Then you can use sophisticated software, and you can use a platform that will allow you to share the screen in a reasonably sophisticated way. Then at the other side, in fact, at the other side, the software and the trainer is to be less equipped than the actual endoscopy room where the trainee is. And again, you can come from simple software to now virtual augmentation software, where you can actually put your hands and pointers into the screen that the endoscopist is transmitting to you to help him aid that. Of course, the companies are fully aware of this, and this is Pentax have got into it. And for those of you who don't know, I'm a flying trainer for Pentax, primarily because I'm interested in being able to try and do this in Africa. And again, you can see that there's the hardware in the transmission, there's the images that you can get from that. And again, the software will allow you to switch between images and do picture in picture. And then here is the hardware in the classroom itself, if you want to transmit these procedures. And in fact, a lot of this has gone on in the transmission line of things. So experts doing cases, and you can only learn so much from them. You can't actually learn how to do it from just seeing an expert perform it. It just whets your appetite. And if you think you can do it, I can assure you it's not as easy as just watching a couple of demonstrations. This is the company that does it. It's been around for a long time. And it's originally started doing it for surgery. Again, you might have seen on BBC, they did robotic prostatic surgery on the BBC, again, using this sort of technology. How can you do it simply? So you just need to know that almost all endoscopic devices now have a DVI output, which you can get a cable that goes to an HDMI. There are other ways of capturing the signal, but that's much away the simplest now. You then obviously connect these things together. And if you use open broadcast software, that's what the gaming people use to live stream, you can capture these images and you can capture them from each device. And again, you can vary which one is big, which one is small, and vary the inputs. Again, you need a reasonably sophisticated computer to do that. And here's one of the switches where you plug in your devices to from the X-ray machine, the ultrasound machine. And again, I can't say enough that if you read the gaming literature, you can see how to do some of this stuff. But you can actually use very simple platforms. The one we're using today, I've used it, and we're in the process of setting up. We've done 4 trials with Namibia, and so we can do it to Windhoek. Unfortunately, the only institution there that has a decent internet connection is the private hospital, but the individual works both in the private and the public sector. And so we're about to roll out this proximity system to try and support him maintaining his skills in EUS, because he's not naive, but he isn't experienced. So I hope I've sort of given you a bit of a flavor of what might be possible. There are a lot of logistics involved in it. There may be also some ethical issues that need to be addressed when one's doing it. I don't really have time to go into those. And I'd just like to conclude by saying a few things. I think there definitely is a great need for endoscopy training. I've visited all those centres that you've seen on that first WGO training centre. And I think there's also areas in South Africa where the standard of certainly of more than basic endoscopy is lacking and might well be improved by this sort of technology. Again, proof of concept definitely exists. I think the technology is definitely easier. And I think it's a way of sustaining support for training initiatives and workshops that you do that are very likely to make a difference in establishing skill sets in more remote areas. And also it has the thing that it doesn't have a carbon footprint of any note, whereas visiting these places is definitely something that is logistically more difficult now, apart from the carbon footprint as well. So on that basis, I'd like to sort of close, and I'm happy to take any questions regarding what I've just alluded to in this presentation. Thank you. Can you, Chris? You're muted, Chris.
Sorry about that. I just had to take a quick call.
That's okay.
So there are no more questions in the chat session.
Yeah.
Are there any more comments?
I'd just be interested if anybody would like to say that they think that this would be applicable in their setting, and do they think there is a role for it? I'm obviously a convert to it and have been spending a lot of time doing it. And I think there are problems with it. The WGO is going to set up its own version of it, and it's going to start in Fiji, but it's called TERM. Telementoring.
Sandy, surely the first issue is cost.
Yeah.
I mean, any ideas about what kind of costings you would be looking at?
So you need a reasonable computer to do it. You need a switch that costs about 1,000 Rand. And you need a few cables that will probably cost you 2,000 Rand. And you need a good internet connection. That's all you need. So you can do it very much so. The Proximy people take a video camera. They go around the back of all the devices in your room. They don't even come and visit. They pack it up in a box, in a sort of, it's a bit like one of these armored carriers that they use for transferring weapons in the US. And they park that in your institution and guide you through it by Zoom, how to connect it and how to make the connections. So I think it is, they obviously charge and they run their system through the internet. But obviously Zoom is of no charge if it's on an educational platform. So the method that we've tried out in Namibia is definitely low cost and high quality transmission of images. So
Sandy, there's a comment from Acqui, I think from Brown University, about this issue and the fact that the challenges seem to be more financial than actually a lack of interest. Do you want to expand on that, Acqui, by unmuting and unvideoing?
Yeah, I mean, I think, you know, I think we all seem to have an interest in training or, you know, being trainers, trainees, et cetera. But the challenge, like I said, is just the money. So how exactly could we solve that that issue. I think there's only so much begging one can do. And I think sometimes some companies don't necessarily see our continent as a potential for growth. And maybe that's why they're not investing in there as much, who knows? So that's my question. How do we go around the financial component so we can meet these targets of training? Because it's a never ending story of what we need to do in training, but we just need the money.
Yes, I think one way is to develop a relationship on a one-on-one basis with a single institution in a country. And then you develop that relationship. And it would seem to me in Africa that one of the things that one might be able to do is to develop that relationship with a private hospital, with someone who's working both in the state and the private. Because many of the private hospitals do have access to high quality internet. Bandwidth in Africa is actually quite good. Again, the next step is to actually see if they can get that bandwidth into the endoscopy area or the operating area. Again, they could perhaps perform the procedures in the operating room instead of an endoscopy area, so that they only need one connection. So for me, it would be a motivation to get capital outlay to get a theatre sorted out. And I know Jerry Way. He's set that up in a peripheral hospital in Ghana. That's not in Accra or in one of the major centers, but in a smaller town. And he's demonstrated live teaching, live telementoring to the WGO. So it is definitely feasible. And I think for the likes of people like Chris and I, who are semi-retired, we don't run busy clinical practices, we don't have university admin around our neck, that obviously this telementoring would take time for procedures like EUS and especially interventional procedures. But I think it's definitely doable. And for me, that would be the model for a few of us to try and develop an individual relationship like I'm trying to do in Namibia, and to try and take that forward. Perhaps you could set up somewhere in Ghana and or Zambia and do the same there, because I think it's a great way, not for teaching naive people, but for helping individuals who need help with decision making as well as some of the skill set.
Okay, if there are any more comments or questions, please post them now. Any final comments? Sandy, Chris Ziady, thank you very much.
I'm good.
So that concludes the session, and thanks very much to our speakers. Chris, very nice to see you after a long time, and I hope you'll come back to our endoscopy gecko session.
I'd love to. I will be.
And thanks to ECHO, University of New Mexico, and our ECHO India team who gives us and provides us much support. There's a feedback form after the chat, please, which we'd like you to fill in if you can. All these recordings are posted on the Gastro Foundation website, so they're available for you to view at no cost. Thanks to Cheryl and Karen from the Foundation ECHO team who keep this support going. And next week, we have a very interesting gecko session, which is devoted to IBD. We'll be discussing the side effects and adverse effects of the PD-1 channel blockers, which are now used quite extensively by oncologists, focusing on both the liver and the colitis that these drugs have associated with them. And so just some final comments on gecko and what we hope to expand in the future. We have a very nice program with the AU that we're going to roll out and which we'll advertise. But these sessions are actually very infrequent, every 4 or 5 weeks, but it's really it's a way of networking and also gaining interest on what how we can go forward from here. If the interest is there and the motivation from the presenters is there, we will take a particular topic out the weekly session and make it more often, make it available more often on perhaps an every second or third week basis, or perhaps even a weekly basis. I know that Ed Jonas is very in favor of doing this for screening and treatment of liver cancer. So these weekly sessions are really to test the waters, see what the feedback is, see what the support is, and if necessary, we'll make them more available more often, and kind of get deeper into the subject. So on that basis, then, thank you very much for all your support, for your attendance. Thanks to our speakers, and see you next week. Goodbye.